Right, good evening, everybody. Thank you for coming to join us for this BLTG webinar on HHV8. I'm Oliver Tabberby, and I'm co-hosting this tonight with Dr. Jonathan Potts from the Royal Free. I'm delighted to welcome the Cambridge team who are going to take us to a case and then give us an overview of where we are in this emerging topic. Dr. Georgina Jarman is a research fellow based at Cambridge, and she's going to start the case presentation, and then Dr. Will Webb is going to give us our state-of-the-art lecture. So I'll hand over to you, Georgina, to crack on with the case. Thanks a lot.
There we are. Thanks very much for the invite. Thanks, Georgie, for the case presentation. Thanks, BASL, again for the invite. And my name is William Webb. I'm a hepatologist down here in Cambridge. Something I'm not is a virologist, so approaching this very much from the clinical perspective, but have been involved with a couple of cases here locally and then discussion with others who've had other cases. And this is something that's become more prominent and really been feeling our way as it's been something that's taking our attention, both with the testing regimen that I'm about to discuss and some of these people, like the case Georgie's just discussed, who've been so unwell. I'm going to start with this slide, which may be a little bit of a surprise, but the point here is to place this in a little bit of historical context and discuss quite how prominent HHV8 was 40, 50 years ago. So what this is the first appearance in the mainstream media, so the New York Times, of the start of the HIV/AIDS epidemic, so 1981. And what was happening here is there was an employee in the CDC, so the Center for Disease Control in the States, who noted a large number of requests for pentamidine from a number of clinicians based in different places in California. And that, of course, being the treatment of choice at the time for PCP or PJP, and heralding the appearance of the immunosuppression that comes with AIDS. And they started looking into this, the CDC started looking into this, and actually what they found on top of that was what's mentioned here as this rare cancer seen in 41 thought to be well young men, homosexuals, as it says here, but this led to the identification of the immunodeficiency that was ultimately linked back to AIDS and was also the start of what became the diagnostic or the route to identifying HHV8 as the causative agent for Kaposi's sarcoma. So there's a husband-wife team, Chang and Moore, who demonstrated different DNA present in tumor samples from young men with HIV and Kaposi's sarcoma that was ultimately demonstrated to be HHV8. And this, of course, grew and grew. So the CDC report, so became this morbidity and mortality weekly report pictured in the top left. And this became very prominent in the public eye. So you've Freddie Mercury in the center there, who ultimately succumbed to AIDS, but with Kaposi's sarcoma. And in the top right, you have Tom Hanks as Andrew Beckett in the film Philadelphia, which was all around a young lawyer, but who was HIV positive, and this becoming immediately apparent to anyone who noticed these violaceous lesions on his chest, so Kaposi's sarcoma. And the same with Ron Woodruff, portrayed by Matthew McConaughey in Dallas Buyers Club in the bottom corner. And then from a more contemporary approach, I think people have stopped thinking about HHV8, stopped thinking about Kaposi's sarcoma largely as the drugs for HIV, where so many cases were coming from, have become so much better. And you might think, well, why talk about HHV8 again now? And then what's happened is that essentially there are a number of cases, people noticed a number coming up to the early 2020s that led to SABTO looking back over everyone who'd been reported and tracing back people who'd received organs from the same donors who had donated to those who had developed Kaposi's sarcoma, exemplified here from an image from a case report from a team in Belfast for a patient transplanted in Kings. And you can see the violaceous lesion over the Mercedes-Benz type scar for her liver transplant. And this look back led to the document pictured on the right. So this from SABTO, so the Advisory Committee on the Safety of Blood, Tissues and Organs. And the key part of this that leads to our current situation is that universal donor testing was recommended as part of this. The report actually had quite a striking core message. So if one looks back at the numbers that SABTO revealed, they went back over approximately 6 years, so that's 2015 to 2021, identified 27 HHV8 positive transplants. So specifically that's seropositive, which we'll get onto a little bit in a moment. 14 of 27 cases transmitted, i.e. the HHV8 was transmitted from a positive donor to a previously negative recipient. And then 8 out of 14 of those died. And if one follows that through, that gives one a pretty stonking quoted case fatality of around 30% for HHV8 seropositive organ donation. And I think that was really attention grabbing. And then, as I say, this national testing program introduced in the middle of 2023. We have, as you've just heard, one of recent cases in several of the liver units. I think perhaps not much UK familiarity, partly because we're in a low prevalence area. And then just recently, NHSBT have had an HHV8 fixed time working group to try and grapple with some of the issues that this has all thrown up and what to do next. All of this is happening, all of this is a bit of a moving feast, but that is why I think it's important to talk about HHV8. I'll just say here, and I will say again at the end, so Dr. Ines Ishiro-Lum, who's NHSBT's lead virologist, has been instrumental in setting up the program and very helpful to me talking about some of this. So what I'm going to do is I'm going to talk a little bit more about what is HHV8, talk a little bit about testing for HHV8, talk about HHV8 in transplant recipients and really liver transplant recipients, talk a little bit about treating HHV8, the local, so what we've had here in Cambridge, and then importantly the national picture, and then what next. The picture on the right for interest is a primary effusion lymphoma culture with virions of HHV8 arrowed, and the reason this was celebrated in the literature is it's particularly hard to culture. So but by taking cells from this vigorous lymphoma that can arise from infection. Team, this is in New York, the same team who made the initial discovery, were able to culture it. What is HHV8? And it says at the top here, you can see HHV8 is also known as Kaposi sarcoma herpes virus, so one and the same thing, with the name HHV8 being preferred by sort of international bodies who make decisions on such things. And it's one of a huge number of herpes viruses. So what this is on the screen in front of you is a phylogenetic tree, a simplified one. So if the branches are closer together towards the top, then the viruses or the herpes viruses on those branches are more closely related. So ignoring mollusks and fish and amphibians, we've got the central column, got terrestrial vertebrates. And along the top, I've put the human viruses in green. So from left to right, you've got herpes simplex 1 and 2, varicella zoster. So that's HHV 1, 2, and 3, respectively. Next along, you've got CMV, HHV 6, HHV 7. And then further to the right, you've got EBV and HHV 8, which I've arrowed both of. And the reason I've done that is, although they're not together in terms of numbering, with EBV being HHV 4, they're numbered sequentially in the order they were discovered. They are the closest together of the human viruses. So HHV8 close to EBV. The other viruses here are other primate viruses, but not considered to cause human disease. So rhesus rhabdinovirus and some other things. And then if we sort of reformat that, as it were, into a table with the various HHVs, so the 8 herpes viruses down the left, and some simple characteristics along the right. You see some early information about how these differ. So the thing that's really similar about EBV and Kaposi sarcoma virus, or HHV8, is that they both show latency in B cells, or particularly memory B cells, as opposed to either being latent in nerve ganglia for zoster and simplex, or in a more diffuse subset of leukocytes, as with HHV5 or CMV, and 6 and 7, which is more closely related there, beta herpes virus. And they're all DNA viruses. And then thinking from the point that one's said that EBV and HHV8 are similar, there are also some differences. So in terms of similarities, as I say, both DNA viruses, they both have this salivary transmission. People are familiar with glandular fever, and it's incompletely defined how HHV8 is transmitted, but a lot of salivary shedding and transmission through saliva and sexual contact. They're both hemato-oncogenic, i.e. they cause hematological cancer. So there are only 3 viruses that are known to do that. That's these 2 and HTLV1. They both show this increasing prevalence with age, people picking up infection as with time and with contact with others, compared to the alpha and beta herpes viruses. They show fairly low ganciclovir sensitivity, or valganciclovir sensitivity. They're non-neurotropic, i.e. they don't affect the brain, so you don't get encephalitis or meningitis with these, but one does see that with some of the other herpes viruses, and they do both show B-cell latency. In terms of differences, there's endothelial infection from HHV8, there's nasopharyngeal epithelial infection with EBV, hence the link to nasopharyngeal carcinoma. And I think really key to the presentation of HHV8, as well as the endothelial infection, is this inflammatory cytokine encoding. So primarily this is what gets termed VIL6. So this is a IL-6 interleukin 6 analog, V for viral. And then there are some other inflammatory compounds, so some viral chemokine ligands and otherwise, but that generate this cytokine-rich response when there's viral replication. And here's a cartoon of the life cycle of HHV8, which mirrors that of the other herpes viruses. So they all have this latent cycle here on the left, or a latent phase, and a lytic cycle here sort of in the center of the diagram. And one has infection of a B cell. There's some discussion about the precise receptor, but certainly once the B cell is infected, one has viral episomes form in the nucleus, and then an ill-defined process that leads to either recirculation of the cell in the latent cycle, or possibly active replication with movement between those two. So when there's recirculation, there isn't significant cell division, cell replication. There is, however, expression of a few genes. Most important amongst those are, number 1, LANA1, which is what Georgie was showing earlier when staining for HHV1. So this is the latency-associated nuclear antigen, but it binds the viral material to the host DNA. And also viral IL-6, there's a low level production of that, and that's thought to be useful to the virus because it promotes maturation of the B cell towards plasma cell. And then if one enters a lytic cycle, which can happen either through this replication and transcription activator gene, which is conserved across all the gamma herpes viruses with analogs in the other herpes viruses, one can flip between them, and sometimes primary infection, one gets active replication of B cells and active replication of virus within B cells. And if this is not controlled by an immune response involving cytotoxic T cells, NKTs, and some others, and of course limited in various forms of immunodeficiency, including HIV, but for our purposes, transplantation, one ends up with increasing viremia and further reinfection of other B cells. Infection of endothelial cells with malignant transformation into these spindle cells, and cell death. And additional immunosuppression can tip the balance, additional viral infection can tip the balance, and there are also a number of factors that really aren't clear to people. And you might remember from the table a couple of slides back that I said that there was one difference between EBV and HHV8 is differences in the pattern of their seroprevalence. So EBV is hugely widespread, with a significant majority of the population in essentially all countries being infected by later adulthood. 85, 90% of the UK population being seropositive. And that contrasts quite significantly with HHV8. So in this table, the darker colors show a higher seroprevalence. And you'll see there's this area across sub-Saharan Africa where things are, the levels are particularly high, the seroprevalence is particularly high. Northern South America, and also, although not shown that well on this map, you can see Corsica is particularly red, but Egypt, Italy are darker, and the Mediterranean basin is somewhere where there is generally said to be more HHV8 seroprevalence. And at the bottom of the diagram here, I've put the UK seroprevalence estimated at around 1%, which is the sort of figure that one gets in a lot of the literature. And this will contrast with what you'll see in relation to donor testing a little bit later. So having said a little bit about HHV8 and its characteristics, testing for HHV8, which has become something that, we've started receiving results back for, but I think a lot of people might not be so familiar with. And really, the first part of this mirrors all the other herpes viruses, in the sense that there are certain antigens that can be present in the latent phase and those in the lytic phase. There are a lot more antigens present in the lytic phase. And these two photographs are taken from immunofluorescence staining from the manufacturer CyMedX there, of the kit that's used by NHSBT and by a number of transplant centres worldwide. And you can see on the left this nuclear, relatively faint green staining, which goes with the latent infection. This is LANA1 primarily, again, and then the lytic antibody, you'll see there's a more peripheral staining there, and this is much brighter. And these are the two tests when one's having serology reported that one's getting back. One of the things to note with these, and one can think about it, I think, looking at these best they've got pictures from the private lab, is that there could be quite a lot of room for interpretation based on how strong the fluorescence is with the secondary conjugate, and whether there's anything else interfering. And then on top of this, similar to what people will be familiar with say, CMV or EBV, there's a peripheral blood HHV8 DNA PCR. And this is, as with other herpes viral infections and transplantation and immunosuppression, critical. And at the moment, here at least, it's a send-off for us, and turnaround is about 2 weeks, which has been something that's been a significant challenge with dealing with some of these patients. Although there is the star here is to remind me to say that there is a private service we've been using with 24-hour turnaround, and I know some other centres are somewhat better equipped, but that's something. So there's DNA PCR for active viremia and to measure quantitative changes, and then the latent antibody and the lytic antibody, seropositivity for either of which demonstrating infection. And this is sort of just to give a flavour, but on the left, both of these stains are for LANA1, so that latent nuclear antigen, which I described earlier, and just showing quite how dense essentially HHV8 is within. This is Kaposi's sarcoma. One gets a sort of a feel from bottom right towards top left of the stretched out nature of the cells. And on the right, these are both in a patient with AIDS. You can see B cells with these depositions, dense depositions of HHV8 within this smear. And what we get back, and I suspect people listening will have seen some of these, are these documents that come back from from NHSBT, from the lab in North London. And these are organ donor HHV8 results. This is what we're getting back first. And you can see the 3 lines here. There's the lytic antibody, the latent antibody, in this instance, positive, and result to follow, with the HHV8 PCR taking a little longer. As Georgie pointed out in her presentation, results generally being returned around 2 weeks after transplantation. if donor seropositive PCR testing is being performed, and then if donor seropositive, there's a request for recipient serology to ascertain whether someone is a mismatch and therefore understood to be at higher risk of disease. With NHSBT have a central recommendation for follow-up sequential testing and consideration of immunosuppression modulation, although that last is not defined. And there's most concern in mismatch patients, as there is with CMV or EBV, and of course with a relatively low population seroprevalence. If the donor's positive, it's very likely that the recipient or the donor-recipient pair will be a mismatch. And to proceed from that, so from testing the HHV8 related disease, this first slide is really florid Kaposi's sarcoma disease, and you can see so the panel on the left is taken from a review paper about Kaposi's sarcoma and HHV8 in general, and the one on the right is actually just a Wikipedia image, but one gets these violaceous, so vascular endothelium derived patch-like lesions, which can be single or often multiple, more often multiple in immunosuppression. And they can be really florid, as most of the panels here are, or they can be really quite, or in my mind, relatively subtle, this lesion affecting this person's palate in panel E. And there's a certain predilection for the mouth or for the oropharynx. And why that is not entirely clear. And there's some predilection for the site of entry as well, but it can pop up just about anywhere. And one of the things for these transplant patients who are exposed is warning them about any new skin lesion. And Kaposi's is actually traditionally subdivided into these different subtypes. So one has classic, which is associated with immune senescence in higher prevalence areas, and this is what was described by Moritz Kaposi, who was worked in the Austro-Hungarian Empire when it existed, going down towards the Mediterranean coast, and described numbers of old men developing these violaceous sarcomas, idiopathic multiple pigmented sarcomas, he said, and those are relatively indolent. One then has these endemic lesions, which to some extent mimic Burkitt's lymphoma because they give this really aggressive disease seen in Africa, often seen in the context of poorer nutrition, epidemic and AIDS related, with risk related to CD4 count, i.e. worse immunosuppression, more likely to get Kaposi sarcoma, which is very aggressive without antiretroviral therapy. That which is associated with communities or patients, men who have sex with men, and that's often infection site localized and relatively indolent. And then really the core topic here, which is iatrogenic as it's termed, HHV8 associated with solid organ transplantation, which is pretty variable in how aggressive it is, but can be really very aggressive. In transplantation, so iatrogenic HHV8 disease has various labels ascribed to it, and I'm afraid this central Venn diagram is me, but they all seem to run one into the other. So there's very much a spectrum here of what one gets. The two on the left are a lung transplant patient and a liver transplant patient, both of whom one can see the typical Kaposi sarcoma lesions close to the scars where they've been operated. But actually, the Kaposi sarcoma, i.e. the endothelial sarcoma, may or may not be present. An inflammatory syndrome may or may not be present. Castleman's disease, which I'll talk about in a moment, but is a sort of a variant inflammatory syndrome with particular findings in the lymph nodes, may coexist with Kaposi sarcoma or happen by itself. And as may these lymphomas, so a more traditional post-transplant B-cell, plasmablastic typically, lymphoproliferative disease mimicking that which one sees with EBV, or particularly aggressive liquid lymphoma and primary effusion lymphoma, which almost invariably is associated with concurrent EBV viremia. And the yellow bar here is demonstrating the observation. This is a repeated observation when people have written up series of HHV8 infection in transplantation, that transplantation of the lung or the liver is much more associated with disease developing in the recipient than transplantation for kidney, which in turn is more risk than the heart, and in turn more risk than bone marrow transplantation. Reasons for that not entirely clear, but speculation relating to the amount of lymphoid tissue transplanted, and that being a proxy for the amount of virus and virally infected cells transplanted. Particular concern here in Cambridge has been intestinal transplantation, although we haven't seen a case of HHV8 in intestinal transplantation as yet, but with the, really one walloping amount of lymphoid tissue that is transplanted there, and the two significant immunosuppression that's used for those patients. So we have this spectrum of these diseases, one running into the other to an extent, and not particularly tightly defined boundaries between them. I'm just going to talk a little bit about some of them, but leave the lymphoma largely to one side. The first of those is Kaposi sarcoma inflammatory cytokine syndromes. This is the diagnosis of the person in the case report you just heard received. And slightly confusingly, I think, one doesn't necessarily have to have Kaposi sarcoma itself, but Kaposi sarcoma herpes virus infection with an inflammatory cytokine syndrome, which is a slightly vague thing, but this is the working case definition from the initial paper 2016, Polizotto. You can see the reference at the bottom that came up with this. So essentially, there's a list here of symptoms which are somewhat non-specific: fever, edema, cachexia, and disturbance of various organ systems, respiratory and GI. Lab abnormalities: anemia, thrombocytopenia, hypoalbuminemia, hyponatremia, and hepatosplenomegaly plus or minus lymphadenopathy, and body cavity effusions. But to my mind, a non-systemic inflammatory response associated both with viral replication directly, but also significantly with the large amounts of cytokine that is released by viral replication. And something that this paper went on to describe was very high levels of IL-6, which we've talked about, and also IL-10 and some various other cytokines. Evidence of systemic inflammation with high CRP, also somewhat non-specific. Critically, evidence of HHV8 viral activity, so with a significant viral load. Here, a bit of a definition of exclusion, but the absence of Castleman disease or multicentric Castleman disease, which I'll mention in 1 second, but being this related, very similar appearing phenomenon that one sees with HHV8. And critical to this was that this comes with a really awful prognosis. So this was first described in HIV patients, but has since been described in numerous transplant patients. And you'll see on the right here, this study, the red line is patients who developed Kaposi sarcoma inflammatory cytokine syndrome, variably treated, but with a more than 50% 1-year mortality, which was hugely outstripped similarly immunosuppressed HIV controls managed at the same center. So, this devastating inflammatory syndrome. And similar but contrasting to that is multicentric Castleman disease, which is manifests very similarly. The diagnostic criteria are exactly the same, except for without the last panel, which was the absence of multicentric Castleman disease, hence some of the difficulty in distinguishing one from the other. And here, this is an inflammatory cytokine syndrome, but associated with these particular sheets of IgM and lambda light chain restricted plasmablasts around germinal centers in lymph nodes, and associated with lytic expression of the virus. So in this immunohistochemistry, or these two histology slides, you can see the germinal follicle with the 2 feeding vessels at the bottom, or one on the right-hand panel, with these sheets of dense nuclei plasmablastic cells around, and then multiple staining positive for viral IL-6 on the right. And this is typically treated with chemotherapy and rituximab in HIV, and it's those principles that have been extended to the transplant world. Highlighting this spectrum and these poorly defined boundaries, between diseases, people who are successfully treated for this have a high rate of developing either lymphoma further down the line or Kaposi's. And then in terms of how one broadly approaches treating these, this is taken largely from experience, because numbers of cases in comparable circumstances are very hard to do direct head-to-head comparisons from. So there's immunosuppression reduction. And you'll see further down the list here where I say prognosis. So the immunosuppression reduction to clear HHV8 often has to be very profound. So by way of example, there's a statement here which comes from a French series, which I'll mention a bit more in a moment, but the extent to which they had to reduce immunosuppression to clear HHV8 when trying to treat that way was enough to cause graft loss in a majority of renal graft recipients. There's sirolimus, which is a method of reducing the overall burden of cellular immunosuppression, but also some laboratory suggestion that it has direct antiviral efficacy. There's chemotherapy to try and kill spindle cells where there is actually Kaposi's sarcoma. And there is recently quite a lot of literature in the HIV world about using immunotherapy, so anti-PD-1 to invigorate, awaken the immune system, pembrolizumab. But this is generally thought to be contraindicated post-transplant because of the significant risk of causing fatal or rejection, or certainly graft loss. And the numbers I've got here, prognosis in transplantation, as I say, this is from a review paper here, the citation at the bottom, but you've got about 1 in 10 mortality from mucocutaneous Kaposi's sarcoma. If it's visceral, so disseminated, you've got a majority dying. And for both primary effusion lymphoma, the more aggressive form of lymphoma associated, and Kaposi's sarcoma inflammatory cytokine syndrome, both greater than 50% mortality. So something that's without huge numbers of cases to draw from, very high mortality in transplantation, or a requirement, which isn't something open to liver transplantation, of reducing immunosuppression enough to allow graft loss to clear the virus. Something that has very recently been described, so this paper came out at the end of 2024 from a group working in Sicily, in Palermo, is really extrapolating from work in HIV with Castleman's, as I mentioned in passing earlier, and also EBV, particularly in stem cell transplantation, is treatment with rituximab. So one's using this cytotoxic, primarily cell-mediated cytotoxicity, anti-CD20, so B-cell targeting antibody, much, as I say, like the hematologists will do for significant EBV viremia-free lymphoma in some of their patients, and using this to treat, they had 11 cases of Kaposi's sarcoma inflammatory cytokine syndrome, 10 in a liver transplant recipients, 1 in a lung recipient, mirroring that pattern that I mentioned earlier, where it's liver and lung recipients that are most at risk. They did look at the whole transplant service with transplantation of other organs there. And 2 of those had concurrent Kaposi's sarcoma, but the majority were isolated Kaposi's sarcoma inflammatory cytokine syndrome. And the really striking thing here is this table. I've left off the p-value that came with it, which was significant given accepting the very small numbers, is you've got 3 out of 4 who didn't receive rituximab dying from their K6, so consistent with the awful prognosis reported earlier, elsewhere. And then a majority in this series treated with rituximab surviving, so 6 out of 7. And as I said here, this is also effective for Castleman's in HIV, but without corroborative information in transplantation. One of the things that was difficult about this and the way it was written up, and by comparison to the case you've just heard about, is that it wasn't quite clear how early in the disease course rituximab was given here, and certainly the quoted viremias in the paper were much lower than the 10 to the 8, 10 to the 9 that you saw on Georgie's graph, and I'll show again in 1 second. But certainly promise for rituximab, quite likely to get full efficacy needing to be given earlier in the disease course, and at least in principle, at least, unlikely to offer complete control of Kaposi's sarcoma once the malignancy has started, so likely to need recurrent, a concurrent treatment there. So I've got some slides here on the local and national picture, so what's been happening, and actually going to deviate from both of those with the first slide by talking briefly about France, but this is the only really significant prospective transplant work with HHV8. There are some smaller centre bits of work. The UK experience, once it's written up, will be significantly bigger than this, but this was a one-year study in France from a number of centres looking at liver, heart and kidney recipients, Lebe et al. And they had a 12% donor seropositivity, this second point here, through a combination of latent and lytic antibody positivity, found that just over a quarter of those transmitted, and at least in this study, no significant difference between transplanted organs. And then I should say, actually, importantly, they didn't measure the donor piece DNA at transplantation, so they didn't have that information to them, but available to them. But just in terms of antibody positivity, no significant difference between transplanted organs in terms of transmission, but only the liver transplant patients who became viremic post-transplantation, again, matching this report that the liver transplant recipients are most vulnerable. And 4 out of 89 developed viremia, and 2 out of 4 developed a definitive complication, so Kaposi sarcoma and hemophagocytic syndrome. And I think this is a different way of describing the same Kaposi sarcoma, inflammatory cytokine syndrome, and one of them died. So much better numbers than, or less worrying numbers than the NHSBT data, and highlighting the need for good quality prospective data to give accurate understanding of quite what proportion of these patients transmit. But I think importantly, lacking the donor PCR information, which as we'll see in a second, is so important in predicting transmission. So in Cambridge, for interest and to add a little bit of supportive data to what Georgie told you about our case, we've had 19 seropositive liver donors. We've had 4 liver viremias and 1 extra kidney pancreas recipient who became viremic, having received organs from one of the same donors as one of our livers. And of those 4 livers, 1 has been absolutely fine, having been viremic briefly and cleared it spontaneously. 2 have died. The case you heard about earlier, and another, and 1 liver recipient at the moment with an ongoing viremia that we're managing. We've had 2 since universal testing, so that's the best part of 2 years now, late HHV8 associated lymphomas in liver transplant recipients be identified. And interestingly, both of those acquired HHV8 post-transplant. We were able to go back and see that they were seronegative and their donors were seronegative at the point of transplantation. And that's an image from one of their scans there. And then you've already seen this graph on the left, because Georgie showed it, but demonstrating this slow but relentless really increase in HHV8 viral load over a number of months from transplantation in this patient with Kaposi's sarcoma and K6 on the left, and with some reduction with rituximab therapy, about 2 log after the first 4 doses, but insufficient to prevent further viremia and associated inflammatory syndrome that ultimately killed him. And the second patient, fewer data points, but who also presented with a similar syndrome, probably with associated lymphoma, and who was treated rather later with rituximab, and it was too late, and a rapid decline there as well. And then importantly, and I think perhaps of most relevance for those listening, is what's happened nationally. So this slide is courtesy of Ines Ashirilum, and with the ugly red writing, me, I'm afraid. And what we've got here on the left, where it says donor HHV8 status, is essentially negative, which means what it says, and then all of the others, intermediate, low positive, and positive with a number of pluses, denoting some level of positive serology. And then with the positive with 4 pluses, this denoting whether the donor was viremic, so had detectable HHV8 by PCR at the time at point of transplantation. So that relatively few, just short of 0.4%, 0.3, between 0.3 and 0.4% of donors, so a small number. And what that's translated into is you can see the numbers of patients who became infected with HHV8, this same observation that liver, so 8 of 9 becoming infected, but only 5 of 15, so a third rather than a majority of kidney recipients, and probably too few to comment on for the other transplant operations becoming infected. But then 5 of 8, so a significant proportion, a majority of the liver recipients who became infected, dying from the disease, and this really being the thing that's I think focused the liver community's attention on this predisposition for liver transplant recipients to be affected and to have a negative course if they are infected by transplantation. And if we lay this out another way, this is borrowing the diagram that NHSBT have made for their patient information sheet, which is available online with the graphic on the left. They've talked about 1,300 liver transplants, 9 receiving HHV8 positive livers from viremic donors, so same information I've just given, but with no clear donor risk profile. I've put an asterisk there because there's work ongoing to unpick actually whether there was something that linked the various donors, but not immediately apparent. And then 8 becoming viremic and 5 dying from HHV8 related complications within a year. And that 5 dying from 1,300 liver transplants, giving the 1 in 260 risk that NHSBT have put in their publication for patients, and that graphic with the 1 purple figure amongst the 260 pale blue figures. So 2 in Cambridge, as I've described, both with this inflammatory syndrome, 1 with lymphoma and 1 with Kaposi sarcoma. Case in the Royal Free, talked to the team there about with the same combination of inflammatory cytokine syndrome and Kaposi sarcoma, and 2 similar K6 type presentations in both King's and Birmingham. Of interest, one of the survivors had primary effusion lymphoma, also in Birmingham, and was treated prior to the HHV8 being entirely apparent to the team there with rituximab as part of the treatment for EBV, viremia, and this lymphoma, and actually managed survive despite that, so escaped grim prognosis there. Other organs okay so far, i.e. within those since this universal testing in summer of 2023, no HHV8 or known HHV8 associated deaths in other recipients of other organ types. And I've said there, no non-viremic donor deaths so far, which is true. So no one who's been seropositive, but the donor not viremic has resulted in recipient death. And I think that's probably the single most instructive finding from the UK work, because that's something that's novel and allows a much cleaner, if one can get the PCR division between high risk and at least lower risk donors. The so far here, and then the asterisk, unfortunately denotes that from previous cases with Sabto, although testing slightly different, there was transmission associated with donors who weren't viremic. So there's that question mark, but at least the current cohort, at least at present, a clear division. And then I think one can look at this, the national picture, in 2 ways, and there's been lots of discussions about this. So this Sankey plot is to show really the relative proportions of HHV8 associated death, bottom right, so 5 HHV8 associated deaths amongst 1,300 transplantations. So one could say a relatively small proportion, and something that's something some people have argued, and compared to, in the same time frame, 60 non-HHV8 related deaths within the first year after liver transplantation. So, and then this just in an attempt to add scale to these So 5 of 9 viremic liver donors dying. But then if one flips this around the other way and thinks of this either that 7 or 8% of 1-year mortality in liver transplantations has been HHV8 recently, or compares to other viruses and the concern that they give and the amount of time that people spend speaking to recipients or potential recipients about the risk from these viruses, HHV8 I think stands out quite strongly. So what I've done here is tried to put together seroprevalence and the likelihood of viremia in donors where there is information, and the likelihood of fatality. So B and C people will be very familiar with, and of course relatively high seroprevalence in the population, appreciable rates of viremia, but really low, very low rates of post-transplant case fatality. HIV, lower seroprevalence, no data on viremia, post-transplant case fatality, a low rate. HHV8, about 5% of donors being seropositive. I didn't highlight that previously, but and 0.4% viremic, but this approximately 50% post-transplant case fatality. So I think really standing out. What to do? I've just seen Ollie appear, so I'm going to hurry up a bit. But what to do? I've got 3 slides left, I think. First, I think, is pre-implantation. Testing is something that is, of course, on a lot of people's minds. This is just an image from a survey article that describes essentially the Italians are doing this, although not acting necessarily on the results before they transplant, but using it as data going into the post-transplant phase. There's a few centres outside Italy, but not really many people doing this. There are significant challenges with interpreting serology if one's using a serological test, which is what the Italians are doing, both as to whether it's positive or negative and quite what risk it brings with it. Overnight PCR is challenging. Incompletely described performance characteristics of PCR, so quite where cutoffs are set to suggest infectivity, and precisely what to do with results is unclear. As I say, I think the other thing that needs to be done is more data is needed. This title here, Rare Disease Registries, Key to Evidence-Based Personalised Medicine. And I think really this is the only option here. These cases are few and far enough between that registry, or at least collaborative reporting, collaborative management, is the only way to learn from them. And I hope that that'll be one of the outcomes of the UK experience. And I think for the community of people treating transplantation, it's considering the diagnosis and unexplained sepsis-like syndromes, or those with hepatosplenomegaly, lymphadenopathy post-transplantation. And certainly, I think, considering rituximab earlier in the disease course. And then what is happening? So NHSBT have now committed to introducing pre-implantation nucleic acid testing. To quote them, the ultimate goal must be a pre-donation NAT plus serology post-donation. Current regime is going to continue for now. There's this patient-specific information produced by NHSBT now online. There are a number of coronial legal issues rolling through. There's a formal SABTO second report awaited. Clearly, there's a large UK case series to be written up here. The donor viremia finding is novel, i.e. the presence of donor viremia carrying such a high risk. It's the largest prospective assessment to date, and of course is pan-national. Rituximab, as I say, I think is well worth further exploration and consider of use earlier in disease course. There are some big outstanding questions about disease epidemiology. Have we just hit a statistical variation, or is there something more here? And are things dying down again? Ines tells me there hasn't been a viremic donor since September last year. And how protective is being seropositive to start with, i.e. if you knew a potential recipient on the list was positive, could you be more relaxed about them? So that's all I have to say. Thanks to Ines from NHSBT, Lucy, who's a virologist here, who's helped me a lot to help me understand the rest of the team down here at Cambridge, the NHSBT fixed time working group, and the invitation to speak. And if anyone wants me, that's me there. And thanks very much.
Thanks, Will. That was absolutely fantastic. Really impressive talk and really comprehensive. And congratulations to Georgina for a case that was really difficult case, expertly managed and well presented. We've got a couple of questions in the Q&A, maybe just to start with, relating to your case, if that's okay. So one question was been asked is, do we know if other organs from the same donor were transplanted, and whether those recipients developed HHV8 related conditions? I don't know whether you're aware of that from your case or not. And then the second question is whether there's any role for plasma exchange in the treatment of patients who develop the cytokine storm syndrome that you've described, Gwyl.
Thanks very much for the questions. The answer to the first, i.e., did any of those who received organs from the particular case, the same donor as the particular case that Georgie described, get unwell? The answer is no. For that case. And plasma exchange, I haven't seen discussed here, but I have seen discussion of cytokine absorption filters, cytosorb filters, and people have described that. But we did discuss that actually with this case and the other K6 case. But ultimately, it was felt that there wasn't enough evidence behind it. But I can see the logic, and I suppose part of the logic behind the tocilizumab that both of them got was, trying to fight down that cytokine storm. And I suspect I could speak for the unit that we might approach things slightly differently if we had another similar case. But that's how they were at the time.
Yeah, what would your sort of reflections be on how you would manage future cases? Obviously, there is a thought you get a further severe case like this, but what would your approach be, having had this experience to date? With that, you mentioned introducing rituximab maybe earlier in the disease course. Is that?
Well, yeah, I think exactly that. So you might have spotted there that I mentioned that we had another person who's viremic at the moment, and in fact, actually, I had lined up and sought approval to give rituximab at a very low viral load because we were so scared as to what might happen. But we also simultaneously significantly reduced his immunosuppression. His viremia actually disappeared, although his liver tests have started to deteriorate. So we've got that, I think, in backup. But that's certainly, if it were, that'd be my feeling. So early rituximab as soon as there was HHV8, or at least confirmed HHV8 viremia.
Are there any commonalities or themes that have come out in the cases that have been described where people have got severe disease? Is there any common theme among the recipients that sort of hallmarks patients who are more likely to have a more severe disease course? Is that?
I don't think so. I think one of the things that was pretty tough, actually, talking to people in the various units, I think that these were recipients who, on paper at least, would have done well if they hadn't had HHV8. I mean, the case Georgie's presented was a young bloke who didn't have much in the way of comorbidity. Our other case was that. I know that could be said for some of the other cases. So I don't know if the recipients were, particularly heavily immunosuppressed, or in particularly poor nick, or particularly comorbid or whatever pre-transplant. So which I think is one of the toughest things about it in a sense.
Yeah. One of the things that Ollie and I spoke about was how we should be counselling patients undergoing transplant assessment. What has your approach changed in light of the cases you've managed, and how would you advise people who are undertaking transplant assessments and involved in the consent process?
Well, yeah, it has changed, and we're talking to everyone, and we're trying to write down that we've talked to everyone specifically. And I think NHSBT have been helpful there in laying out the numbers, and I think that's about all one can do really at the moment. I think one has to be straight with people, because one gets a pretty common question that comes back is, why aren't you testing for this? Why is this a question? And I think that's going to remain something, and all one can do is give people the information. Something that was a hot topic here is less appropriate to livers, because most of our patients can't really afford to wait. But for those potential liver transplant recipients, or those with other organs, when this was most prominent in our minds, is whether they might decide to wait until things were clearer, and that's really difficult to advise on because the time frame is also uncertain, as well as quite what the individualized risk is, I think.
And is there any clarity on the time frame for introduction of pre-implantation testing? Do we know anything further about that?
No, sadly. I mean, I think it's very much desired, and one can also see that it might come with some other benefits, because it would potentially provide a platform for other testing for other viruses or other rapid turnaround diagnostics that are not available to us at the moment. But no, I think it's quite, talking to people, it's really quite complicated, you know, having PCRs for one person potentially, or nucleic acid testing run at any time across numbers of different sites, appropriate personnel to run it, like what thresholds one uses, you know, getting the results out quickly and all of that. So I think it's a complicated and expensive thing, but I think at some point it's coming.
And in terms of sort of the recent cluster of cases, do you think that is a statistical anomaly, or do you think there is more to that? I appreciate that's a sort of speculation more than anything with evidence. Do you have any gut feeling about that?
I really don't know, actually. I mean, one of the things, if one looks online but without much evidence behind it, is that there's talk about an interaction between coronavirus or SARS-CoV-2 infection reactivating HHV8, but I'm not sure if that's enough to explain what we've seen. And clearly things were circulating prior to the coronavirus epidemic. And I think also we're incompletely clear, and it's a hard thing to do, at least from the transplant center's perspective, is to compare donor backgrounds. So I think there's some work going on in NHSBT. So I really don't know. I can't believe that we won't see some more cases somewhere.
There's a couple more in the Q&A actually. Just so one question is regarding antiviral therapy, and the question is: so given the poor efficacy of ganciclovir, were there any thoughts about switching to other agents such as Foscarnet, or would drug toxicities prove prohibitive? I don't know. Do you have a view about overall use of antivirals in this? And Ollie's got his hand up as well.
Did you want to speak, Ollie? Or...
Not for this. I'll get in my wait. We'll do the Q&A, and I've got a question separate to the end.
Sorry.
No, well, so both of the K6 patients we chap Georgie presented and our other one both received valganciclovir because we thought it was unlikely to cause harm, even though lower efficacy. We did talk about Foscarnet. I think, at least I hope I speak correctly for the virologists here, not felt to add much, but I think there's pretty limited evidence on this, and something I do know is that the novel CMV agents, which people might be used to using, we did talk about as well, but they don't have any activity on HHV8, or at least are not thought to. So it was I think really similar to really similar to EBV. So I don't think, as a rule, there are people trying to use antiviral or directly antiviral drugs for treating EBV. It's more immune system manipulation, cytotherapy, and so forth.
Yep. Maybe I'll just ask one question from the Q&A before I hand over to Ollie. So someone's asked, should we be using steroids with rituximab for the cytokine storm? The point at which you used Ritux, was that during the cytokine phase of the illness, or did it come before that?
Well, so certainly he was febrile. Both patients were significantly febrile and inflamed when they got their rituximab. They did get some steroids. I think the other thing that was thought about was the potential for a sort of tumor lysis syndrome, like so a preemptive prophylaxis against that. But we didn't hit them particularly hard with steroids, but they had a modest dose to go with the infusion protocol for rituximab here just generally involves considering steroids alongside.
Yeah. Ollie.
Thank you both for great talks. I think it was really poignant, Will, you started off with the AIDS stuff from where we started to learn about HHV8. This is a disease of immunocompromisation as opposed to it being immunosuppressed. The data and this covers a bit of what Brian has asked subsequently. The data regarding kidney transplantation and liver transplantation is fascinating. Do you think we need to evolve how we are evaluating our patients from an immunosuppression perspective, from how we understand what immunocompetency means? Like, where do you think this develops from that perspective? Because there's lots of different ways we are also delivering immunosuppression around the country, and are you seeing signals with that as well, or not? It's a fascinating evolution of where we're going, but as opposed to looking at the virus, I'd be looking at where we are delivering our drugs, surely.
Yeah, I think it's clearly important. I think two points I'd make, and you alluded to. I think it's interesting, isn't it, that on average a lot of the kidney transplant patients and the SPKs, for example, are more significantly immunosuppressed than our liver transplant patients, or at least in terms of the weight of medical immunosuppression that's given to them. So depleting antibodies, especially for the pancreas kidney patients, but those patients tending to do better, which is odd. And then the other thing that stuck in my mind very significantly is Mark Bauer, who I used one of his slides there in relation to Castleman's, has shown there's been a shift in presentation of HHV8 disease in HIV from when there were a lot of people around with very low CD4 counts, very profoundly immunocompromised. Kaposi sarcoma was the dominant presentation, whereas that's flipped to being Castleman's and inflammatory syndromes for people who are more moderately immunocompromised, which I think speaks to, well, that being critical to how the virus manifests, really, and how we respond to that. But it seems logical to try and minimize, at least where there's concern for our liver patients, immunosuppression. Although on the flip side, this chap, he had pretty florid TCL mediated rejection at one point, and quite how one navigates that was really difficult.
But to counter that, that's disorganized immunity, isn't it? It's having T-cell mediated rejection and immunocompromisation at the same time. And maybe anyway, you could move from immunosuppression to looking at T-cell regulation, etc. And maybe that will be the burgeoning field off the back of this.
Maybe I can just finish up, Ollie, by Will, just by asking, how do we think we should approach such cases in the future in terms of corralling the expertise that's required? From your experience, what do you think should be the next steps for the liver transplant community? Because as you said, it feels like we sadly probably will see more cases. How do we have a governance structure around how we get corral expertise nationally, gather the data, but also use the expertise that is available to help patients before we necessarily have data collected?
Well, yeah, I think it's essential, and it's been informative to me with the sort of real-time management of these patients. So one, just mention again, the first chap, advice was sought from the Chelsea and Westminster Malignancy and HIV Service. So that's Mark Bauer, who, although it's a different disease, I think it's the thing with the most analogy, and it makes good sense to tap into there. And the fact that these are still pretty rare, but in the various units. The other thing I've done is I've spoken to at least one person from each of the units where there's been a case and tried to talk through how it's presented. And certainly my own feeling would be it would be an excellent project alongside writing up the national experience of the sort of serology and sort of prospective aspect of it, but a more detailed examination of these cases, how they've done, what treatment they had, and any future ones. I remember bringing up the idea of some kind of registry at the fixed time working group. I think NHSBT felt they couldn't quite support that themselves, but it's certainly something I'd be interested in being involved with.
Great. Well, there's one more. I think it's just come on the. So Mike Allison said, should there be a national MDT for such cases in order to more rapidly gain expertise and consistency in management? So I guess, I mean, that I think probably would be something, and maybe not just isolated to HHV8, but I guess as transplant physicians, we often are faced with what feel like fairly unique circumstances and conditions that we don't have experience with, and actually having a method of corralling that expertise nationally might be one way of just rare disease management overall. I don't know if you or anyone has a view on that, and as to how we organise that.
I don't know so much about the organisation, but I think it's essential, isn't it? And if you know someone somewhere else has had a case and you haven't seen one before, talking to them is invaluable, isn't it? And ideally more than one person.
Yeah.
And I think we should be able to facilitate this through BLTG as a starting point, and I think it's something that we should look to pursue. And like you talked tonight, Will was fabulous on that to even give us insights into what's happening and what's seen. And I think we as a community could grow together and do more as we find out more about this. I think it's been a fantastic evening. I just want to thank everyone for being a part of it. John, thank you very much for co-hosting with me. Will, your talk was fantastic. The same with you, Georgie. Just the only other last things to say from BASL BLTG is that the abstract deadline is Friday, so please do continue to submit your abstracts. It'd be great to see all your work there. But I just want to thank everyone for attending and thank everyone for the questions and answers, and thank again our presenters for their great talks. It was fantastic. See you later.
Thanks, guys.
Thanks for having us.